Hey everybody, my name is Robert. This is my teaching demonstration here for the One Vision. So the topic that I chose to go over today is going to be weaning mechanics for a patient who's been on a ventilator that's going through a spontaneous breathing trial. You're going to come across a scenario that's going to be given to you where you're going to have to make the determination whether or not this patient can be liberated or extubated from the vent, right? So there's different tests here that we'll go over in a second on how we can evaluate. Now, what's important to remember is that not one single test is like the gold standard to say this person's going to pass, right? We have patients in the hospital who pass these tests all the time for whatever reason. They end up going back on the ventilator, right? But what the NBRC wants to know is you, as a clinician, as a therapist, do you understand what these tests are telling you about your patient? Can you make the appropriate choice on to whether or not it's going to be safe for you to go ahead and proceed with that extubation? Okay, so you're going to come across a scenario in the test, and it's going to say patient's been on a ventilator. Hopefully, the initial reason that they got put on the ventilator is resolved, right? That's the first thing we like to do, right? Make sure that we're hemodynamically stable. We want to make sure that we're not requiring high amounts of oxygen, and the doctor wants your opinion on whether or not they're ready to be liberated from the ventilator. Okay, so first test we're going to go over here is we're going to go over vital capacity. Okay, vital capacity. This is a sample scenario here. This male patient who's 5'6" happens to be my height as well. So I already know that his ideal body weight is going to be about 64 and a half kilograms. Okay. So what's important to know about vital capacity? Vital capacity, we want at least a vital capacity that's greater than 10 mLs per kilogram. Okay. So for our patient here, we want to make sure if he's 64.5 kilograms, that for his vital capacity, he can at least get 645 mLs. Okay. Now, how am I going to coach this patient to do this? Right. Well, we got to think back to our lung capacities and volumes boxes on what is a vital capacity. Okay, vital capacity. You're going to have the patient breathe in all the way, breathe in, breathe in, breathe in, big breath, and then I want you to blow it all out, blow, 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 all the way until the lungs are empty. Right. Get that full range, that full inspiration to that full exhalation. That's our vital capacity right there. Okay, so you're looking at the ventilator while your patient is doing this. As long as they come up and they're greater than 10 mLs per kilogram, then we're happy with that, right? If they pull less than that, let's say you have a scenario, your patient's ideal body weight is 64 and a half kilograms, and you do a vital capacity and the results come back and it's 400 mLs, right? So the patient did not meet 10 mLs per kilogram on that. So in that scenario, we're not going to look to extubate that patient yet, right? So we want to make sure. A good rule of thumb is when you're taking this test and it comes across and it's a vital capacity and it's over 1,000 mLs, it's 1,200 mLs, that's a good vital capacity, okay? But if you want to double check and make sure, you got to do the calculations, right? Finding your ideal body weight, converting it to kilograms, and then seeing when I do this vital capacity test, am I larger? Do I get more than 10 mLs per kilogram? Okay, that's important. The next one here is going to be NIF. This is our negative inspiratory force. Some people will call this a MIP, a maximum inspiratory pressure. This is where we're going to tell the patient that we're going to ask them to suck in like they're sucking in on a straw, right? And what this test tells us here is about diaphragmatic strength. We want to see how strong is that diaphragm, because we know as clinicians that the longer our patients are laying down in bed, not participating in physical therapy or exercising, that our muscles begin to atrophy and shrink and decay, right? So we want to make sure that before we pull that breathing tube out, that you have adequate diaphragmatic strength. Okay. I always tell my students when I'm doing this that when you're doing this test, they're going to be sucking against something, and they're not going to get air. So you want to tell your patients, right, before you do this, that you're not going to get air while you're doing this. So you're going to after a few seconds, okay? But in the meantime, you're not going to get it. Give them that warning first, right? Before you just surprise them with it, and all of a sudden they're freaking out because they're not getting air when they thought they were going to get air, right? So good communication during these tests, right? So let's say we have this scenario and we're doing it, and it's going to give you the option, right? I'm going to do a NIF on this patient, okay? And this result comes back negative 20. Okay, negative 20. Remember, NIF is a negative number. Why is that? It's because our diaphragm is pulling down. It's creating that negative pressure, right? So we want it's going to be negative, right? But what's the range here? We want at least more negative than negative 20. Okay, so if I got negative 30, I'm happy with that, right? If I got negative 40, hey, I'm happy with that. If I got negative 10 on my NIF, and that comes across as the result, that's a no-go for me, right? That patient does not have adequate diaphragmatic strength. Therefore, I wouldn't recommend extubating the patient at that point, okay? So the NIF here tells us about diaphragmatic strength, right? Next test here we're going to go over is the RSBI, all right? This is another formula here, okay? But if you know what RSBI is, it's a rapid shallow breathing index, then you already know the formula, okay? Rapid, how fast are we breathing? Shallow, that's a depth. How much are we pulling, okay? So key number here is we want this number to be less than 105, okay? So let's do a scenario real quick. We have our patient, he's on an SPT, and we're doing this, and it's going to say he's breathing 10 breaths per minute, and his minute ventilation is going to be, let's do 8 liters, okay? 8 liters. Now, on your test, they could give you minute ventilation and rate. They might give you a rate. They might actually give you a tidal volume. So then we're going to skip a step. But in this case here, we need to figure out what is this tidal volume that this patient is breathing. So let me pull up my calculator. So if we're at 8 liters, and we're breathing 10 times a minute, that's going to give us a tidal volume of 800 mLs. Okay, so let's remember that 800 mL. So let's do the formula, right? Rapid. How fast is he breathing? 10 breaths. Okay. Shallow. Depth. 800. Now this is the key here is we have to convert this into liters, right? We can't just do 10 divided by 800. That's going to give us a point something, right? So let's convert it, right? Let's do 10 divided by 0.8 from our tidal volume, and that gives us an RSBI of 12 and a half. And we're happy with that, right? It's less than 105. Okay, so what is this test telling you? This test is going to tell you that your patient is breathing slow and breathing deep. Okay, we don't like patients. We want to extubate patients when they're breathing fast and they're breathing shallow, right? So the key here is, if you're breathing 10 times a minute, I need that tidal volume to be at least 100, and that's going to equate to a rough RSBI about 100, okay? If you're breathing 20 times a minute, then I want a tidal volume of at least 200, because that's going to equate down, look, we'll do the math. Breathing 10 times a minute, 2, I'm sorry, I said 20, right? Breathing 20 times a minute divided by 0.2 for 200 mLs gives me a tidal volume of 100, right? So quick easy way to kind of, when you're looking at it and you're like, oh, I forgot the math, right? If we're breathing at least that much volume with that rate, right? So here's another one. Patient breathing 24 times a minute. For me to get an RSBI of 100, I need at least a tidal volume of 240, okay? We're happy with that. If they're breathing deeper than that, then that RSBI is even going to be less for us, okay? But remember, if you know what RSBI, Rapid Shallow Breathing Index, what that stands for, then you already know the formula, right? It's going to be your rate, rapid, how fast, and it's going to be our shallow, how deep is our breaths here, okay? These are the big 3 that you'll probably see on your exam where they're going to want to know, do you know the normal the values for your patients and whether or not it's safe enough to move forward and extubate that patient, okay? Because we as RTs, we love to extubate people, right? That's a joyful moment when we get to do that and get them off that ventilator, right? We just got to be safe. We got to think about it critically and make sure that what we're doing for our patient is the best for them, right? All right, last one here. Your exams, they might say it has an audible cuff leak. Okay, what do we know about a cuff leak? A cuff leak is going to tell us about upper airway swelling, right? If there is no cuff leak, right, that means that that patient's airway is swollen around the tube. If you pull that out, there's a risk of that airway swelling continuing and narrowing that airway and making your next intubation a far more emergent than it needs to be. Okay, so cuff leak is when we want to hear that air coming out and around that tube, so we know that the airway is not swollen around there. Okay, so how do we do this? What's your formula? Okay, it's going to be your cuff up minus cuff down divided by cuff up. Okay, and what we're doing with this is we're putting our patient back on a volume control mode, so I know what kind of volume I'm giving them. Okay, and I'm seeing how much of that comes out of the patient, but I can't see that number, right? What I can see is what's going to come back to the ventilator, and what doesn't come back to the ventilator came around that tube and out of the patient. Okay, so let's do an example. I'm a fan of easy math too. So, okay, so let's do this. So let's say we put them on a volume mode. We're going to do 500 mLs. Okay, that's going to be with our cuff up, right? Now, then I suction above, suction below, and I'm going to deflate this cuff. I deflate this cuff, and I have 250 mLs come back to the ventilator, right? So we're going to do 250. Comes back. Let's do the math real quick. Let me pull out my calculator again. So I'm going to take the cuff up, which was 500. We're going to subtract the volume that came back to the ventilator that I can see as a number. It's 250. We're going to divide it by 500, which was the volume up again before we deflated that cuff. It's going to give me a 50% cuff leak. Okay, now what's a normal cuff leak? Like I said, in these tests, every hospital I've worked at is a little different. If it says an audible cuff leak, we're happy with it, right? If it says absence or absent cuff leak or no cuff leak is heard, and that's a no-go, right? We're not going to extubate our patient. That's unsafe, right? Recommend some steroids or something, and we're going to try again tomorrow, right? But from where I've worked at, as long as that cuff leak is greater than 15%, we're happy with that, and we're going to move forward with the extubation. Okay, so these are some of the main tests: the vital capacity, the NIF, negative inspiratory force, and the RSBI, the rapid shallow breathing index, and this cuff leak that you'll see on your exam. Right, and like I said, the test wants to know whether you're a safe therapist and you understand when it's appropriate to go ahead and extubate that patient, or is that extubation going to possibly cause harm to our patient because they didn't meet those normal values. Okay. So, anyways, that's my presentation. I wish I had a fancy whiteboard that I could zoom in and stuff like that on, but I work with what you got, right? So, anyways, I appreciate y'all, and I'll talk to y'all soon. All right.